So welcome everybody. Thank you for joining us today. It's just turned 1 p.m., so we will start with our webinar. So today we'll be talking about pregnancy and type 1 diabetes with Dr. Patricia Lemieux. And before I present Dr. Lemieux, I just want to let you know this session is recorded as we will make it available on the Better Registry website, either later today or tomorrow. Also, we will be taking your questions. If you want to ask any questions, feel free to do so in the Q&A function at the bottom of your screen. We will come back to the questions at the end of the presentation. So, without further ado, I will present Dr. Lemieux, which is an endocrinologist at CHU de Québec, Université Laval since 2020. She has completed a specialized training in pregnancy endocrinology in Calgary and has strong interest in type 1 diabetes, particularly with using innovative technologies to enhance its management. I know she has a great presentation for us coming up, so I will give you the floor, Dr. Lemieux.
Thank you so much. So I'm really happy to be here today. Thanks for joining the webinar. So I have a strong interest in type 1 diabetes and pregnancy. I've been trained in this field a couple of years ago, and since then I've been working a lot with patients with type 1 diabetes. So I'm really glad to be here today to share some of my knowledge with you. So sorry. Okay, so some of my objectives for this webinar today is to discuss pregnancy planning and importance of preconception care for patients living with type 1 diabetes. We'll also review the management of type 1 diabetes during pregnancy and delivery. And I will briefly discuss the management of type 1 diabetes in the postpartum period. So planning a pregnancy can be really scary for some women with type 1 diabetes. We are always wondering about the risks, the challenges, some has fears about diabetes in pregnancy. So I think that's really important to discuss the pregnancy and to plan it. When you demystify the risk associated with pregnancy in type 1 diabetes, that can really help to be prepared to improve the risk of complications during pregnancy. So when I see some patient for preconception counseling, so first, the planning is key. So I really, really encourage you to discuss your pregnancy plan with your diabetes team and your doctor, because we know that keeping your glucose in the target range really, really help reducing the risk of complication. So when we are in the preconception, so before pregnancy, we will recommend to optimize your glucose control. So usually we will typically say that we are striving for the glycated hemoglobin before 7.0. So as you might know, the hemoglobin A1C shows like the mean glucose level over the past 3 months. So we're aiming for this number to be below 7. So this is a blood work that can be done that can help having a clue about your control. And we know that when we optimize your glucose control before pregnancy, this is associated with a decreased risk of complication, such as miscarriage and congenital anomalies. Second, when I see a patient in my clinic that plans to be pregnant in the near future or that want to discuss the pregnancy, if she's ready to be pregnant, I will review the medication because we need to stop some medication that can be harmful for the baby. So those medication would be like medication for cholesterol, so high cholesterol, and some medication that we give to protect the kidney or for hypertension. So usually we will typically stop them or switch them for medication that are safe for the baby in the pregnancy. We will also recommend to start folic acid supplementation. So we do recommend a dose of 1 milligram. So that can be buy like over the counter in the pharmacy. We recommend to start the folic acid like ideally 3 months before getting pregnant and to continue for the duration of the first trimester. And so you don't need a prescription for that. You can just buy this at your pharmacy. If the patient is not already using the continuous glucose monitoring system, I will strongly recommend to start the system. I would say most of my patients, even outside of the pregnancy, would use like a glucose sensor that we typically like say. But if it's not the case, I will recommend to start it because I will show to you over the next slides, but this can really help to improve glycemic control during pregnancy. So I will recommend to start it before. So we can also help controlling your sugars before pregnancy. Another important thing is to screen for diabetes complication before pregnancy. So just to make sure we're up to date on the screening. First thing to do is really to have eye assessment. So that can be done with your eye clinic, with your ophthalmologist if you're seeing a specialist doctor for that purpose. Second thing we will do is to check for the kidney function. So that will be done by a urine test and a blood sample. If there are known diabetes complications, either the eye or the kidney, I won't discuss that today because that is really an individual discussion to be done with your doctor because it's really dependent on the complication and the severity of the complication. It's not necessarily like a reason not to get pregnant, but we just need to discuss the risk. So because the complication can worsen during pregnancy. So I really suggest you discuss this in particular with your doctor. So for a patient coming to my clinic who's pregnant and who has type 1 diabetes, what do I do usually? So first, one recommendation is to start aspirin, which is an oral medication, to be started between 12 to 16 weeks pregnant. So that needs to be done before 16 weeks of pregnancy. And the goal of aspirin is really to reduce the risk of preeclampsia. So preeclampsia is high blood pressure with kidney dysfunction that can appear in the late pregnancy. And we know that patients with type 1 diabetes have higher risk of having preeclampsia. So that's why we give aspirin to reduce the risk. So that will be prescribed by your diabetes team. So what does it look like, a follow-up when you have type 1 diabetes and you're pregnant? So first, there are two follow-ups. The first one will be with the doctor that will take care of the baby and the follow-up of the pregnancy itself. So we usually recommend high-risk pregnancy follow-up that mostly have like in big centers across in Quebec. So that will be done by obstetrician. So and the second follow-up will be by the diabetes clinic. So this is really a multidisciplinary team with a dietitian, a diabetes nurse, and a doctor who's mostly endocrinologist, but I know some centers in Quebec will be by internists. So those follow-up will be really important to help you have good control in terms of diabetes. And with the obstetrical team, you'll have like more frequent ultrasound to check the growth of your baby. So normally a pregnancy without diabetes, you can have like 1 or 2 ultrasounds during pregnancy. But when you have type 1 diabetes in pregnancy, you'll have like more regular ultrasound, especially in the second half of the pregnancy. And this will be done usually every 4 weeks. What's really important when you have type 1 and you're pregnant is really at the first appointment with the diabetes team, we will really discuss education and prevention. I will show you in some slides in my presentation that there's a period in pregnancy that is really at higher risk of having hypoglycemia. So really, I want to make sure that my patient is okay to treat hypoglycemia and especially severe hypoglycemia. So I will make sure the patient has a prescription for Baqsimi, which is the intranasal glucagon that you can use if you have like a severe hypoglycemia, and to make sure he has it, and to make sure the patient also share like to the people living with at the same house to know that other people can use safely the glucagon as well. I'm not saying that when you're pregnant you have a severe hypoglycemia, but because it's at higher risk, I really recommend to be ready and to know how to react if something's happened. Second thing I will really talk to my patient and the nurse as well is prevention of ketoacidosis. I will come back on the next slide, but ketoacidosis is when you have like high ketones in your blood, and pregnancy is a risk factor to develop some ketones. So I want to make sure my patient are okay to deal with that and to be able to check for ketones. So I will come back to this on the next slide. Also, I will review blood glucose targets required during pregnancy. We aim for more strict glucose control during pregnancy, and I want to discuss that to show some graph about what we can expect, and so the patient can anticipate what will happen over the next couple of months. So just I mentioned, I wanted to discuss a little bit about ketone. So what's a ketone? So that's something we'll learn when we have a diagnosis of type 1 diabetes, and sometimes we need to learn again and then we forget. But in pregnancy, I really want to make sure my patient know what is ketone and how to deal with that. So first, ketone is really an acid that is made when the body breaks down fat instead of glucose for energy. So this is happening when there's a lack of insulin. So the body can't use glucose, so it uses fat, and then it results in some ketones. And when you have high ketones, this is a higher risk for diabetic ketoacidosis, which is a dangerous condition for both mother and baby. So we really want to prevent that. It can occur more quickly in pregnancy. So pregnancy is a risk factor, and usually diabetic ketoacidosis will happen when sugar are really higher. But in pregnancy, it can happen with normal or lower glucose. So it's really important to be aware of that. So when or how do we check for ketones? First, we do check with specific ketone strips. So when you have a glucose meter, you can have strip for testing the sugar, but they also sell specific ketone strips. So that will make sure the patient has a prescription for that and has ketone strips to keep with her, so she can check whenever needed. So when do I recommend to check for ketones? On sick days, when patients have fever. So this is a higher risk to have high blood sugar. When glucose level is high, like above 20, or persistently high, like above 10, 15 for a long time, or especially when there's vomiting, which is something that can happen frequently in pregnancy. So vomiting can be a symptom of ketones as well. So I will recommend to check when patients have symptoms of vomiting. And this is really something the nurse will review with the patient just to make sure she knows how to deal with that. So I know this list can be impressive. It's a risk of poorly controlled diabetes during pregnancy, but this is really the risk, like when the diabetes is not well controlled. So what are the risks of the diabetes during pregnancy? The first one being some miscarriage, so be a little sooner than 12 weeks, and congenital anomalies. But like I said earlier in one of my slides, those risks can really decrease with having good control before we get pregnant. So that's why I cannot emphasize more that it's really important to try to have good control before conception and to plan the pregnancy. One of the risks is the preeclampsia. So I discussed that earlier, which is high blood pressure in this later in pregnancy. The risk of having a C-section, the risk of your baby have increased birth weight. So we know that type 1 diabetes is associated with increased growth, which can result in a baby with higher birth weight. It can also be associated with neonatal hypoglycemia. So when your baby is born, for the first days, he or she can have like some low blood sugar, and this is correlated with the control during pregnancy. The risk of stillbirth, which is a really bad event, but fortunately this happens really rarely. And when you have like a high involvement with the diabetes, which we call retinopathy, this can progress during pregnancy. Good news is that those risks can be reduced with improved glycemic control. So that's why basically you'll be follow up with the diabetes team. So this clinic can help you achieving and maintaining good control, and that really helps to reduce the risk of complication with diabetes. What are the blood glucose targets during pregnancy? So first thing I want to mention, like I said, it is really recommended to use a continuous glucose monitoring system during pregnancy. The two systems that are currently available in Canada are Freestyle Libre 2 and the Dexcom, either the G6 or the G7. I'll come back to this, but the Dexcom G7 is currently the only sensor approved for use in pregnancy. Some of my patients will use the Freestyle Libre, which I'm okay with, but I just do counsel them that, especially with low readings, it can be less reliable. So what are the blood glucose targets? So we are aiming for fasting blood sugar to be below 5.3, aiming for 1 hour after meal sugar to be below 7.8, and 2 hour post meal to be below 6.7. That was typically the way we were handling diabetes control in pregnancy, but now I would say that, I don't know, like 99% of my patients use glucose sensor and continuous glucose monitoring. So we're aiming for that target, but as I will come on the next slide, we're more aiming now for a person in time in a target range. And during pregnancy, we will strive for hemoglobin A1C to be below 6.5 for the duration of pregnancy. So this is what I'm talking about. So because most of my patients will wear some sensors, so continuous glucose monitoring system, we will aim for the time in the green. So I don't know if you can see me moving, but on the left side of the table, you see what's the target for people with type 1 diabetes in general, so outside of pregnancy. So we're aiming for a target range between 3.9 and 10. So this is the usual target range that we're aiming for, sorry. So we're aiming for 70% in that target range. When we are pregnant, as you see, we're aiming for a more strict control. So this range becomes from 3.5 to 7.8. But we're still aiming for 70% in that time. So that can be pretty difficult to achieve. But again, that's why it's important to have regular follow-up, to be proactive with adjustment, to try to keep your glucose in that range. And I don't say that my patients all have time in target range above 70%, for sure, no. But even if the patient have 58, 62, that's better than 40. So I really encourage patients to try to improve that target range by 5%, to make some adjustment, and that really help to gain confidence in control. And an increase in time in target range of only 5% can really decrease the risk of complication for you and the baby. So even if we do not attain that 70%, the more we're getting closer to it, the better it is. Here is a slide about the benefits of continuous glucose monitoring in pregnancy. So those are the guidelines of Diabetes Canada, and they do recommend that in pregnant women living with type 1 diabetes, the technology should be used to increase the time in the target range, so basically to improve your glycemic control. It should be used to decrease the time above target range, so the time spent in hyperglycemia. It also helps decreasing the risk of having a large baby at birth, to have a baby that has some neonatal hypoglycemia after birth, and the risk of having a baby that needs to go at the intensive care unit. Like I mentioned, the only sensor currently approved is the Dexcom G7, and the indication to wear the sensor during pregnancy for the Dexcom is really the back of the arm. Some patients will still use different sites, which is fine, but the indication is really the back of the arm. How we should analyze blood glucose levels. I will come back to on the next few slides about what are the changes expected in your sugar during pregnancy. But really, I really strongly encourage my patient to try to review their reports and to make some adjustment frequently. Because if I talk or I see my patient like every 2 weeks in clinic, even in 2 weeks, some things can change. And I really try my patient to gain confidence in making some changes between the appointment. So we really try to have glycemic control that is up to date and to be okay with that. So we know that frequent and regular monitoring or surveillance of blood glucose help improving diabetes control. And like I said, it's really important to be proactive. So that really help keeping glucose in the range. And like I said, even if we have frequent appointment, making changes between those appointments really help. Ideally, I recommend reviewing reports 1 or 2 times per week if the patient is using a continuous glucose monitoring system. I will show up some examples, but it's really easy to go just on the application and to see the time spent in the target range. So again, like we show up earlier, I aim for the green time to be higher than 70% and to the below the target range, so the time spent in hypoglycemia, to be below 4%. I also suggest to assess, is there some trends for hyperglycemia, for some hypoglycemia? And what really, really helps me is when you record your insulin dosing in your application of the sensor. So really when I see like, oh, she gave 4 units at this meal, oh, that happened to the blood sugar, this is really, really helpful. So at least I recommend to do that like a couple days before the appointment. And you can also enter like some other information that you think your professional will be will like to know about. Like example, if you had a low blood sugar but you went running like 2 hours before, that can be added. I don't want it to be overwhelming for patient, but those are really some tips that can help like understanding what happened and to help you achieve good control. And for sure, if the patient is not using a continuous glucose monitoring system, I will really encourage to keep track of the glucose in a record and and to bring that to the appointment. So when I do go on the application, so this is Clarity, which is the application for Dexcom, what do I look? So I really try to look at this with my patient, so they learn what do I look, and to be able to do that a little bit at home. So first, I really recommend to check only a week period at a time. We will see that glucose and insulin requirement changes a lot throughout pregnancy. So it's really good to look at the last week only. Like we just discussed, I will make sure the target range is set at the pregnancy target range, which is 3.5 to 7.8. This patient was doing really well. She was spending 68% in the target range of pregnancy, but having a little bit too many lows. We recommend for this number to be below 4%. So she was borderline, but yeah, so I'm sure we did address that at this appointment. We can also look at the average glucose, which is 6.7 in that case. In the left-hand side, what I do typically recommend to check is the patterns. So if you click on that, that will give you the overview of the last week and what happened. And then you can try to assess for patterns. Are there some trend for hyperglycemia, for hypoglycemia? What is happening overnight? Are there some post-meal elevation? So this is really a 24-hour period. So this is midnight and midnight. So you really see what's happening throughout the day over the last week. So in this patient in particular, we can see, oh, it looks like a little bit more elevated after like lunch and maybe after supper in evenings as well. So that's something I could discuss with my patient and then make some adjustment. For sure, when I do see some data like this, I will make some changes. So really important to address some hypoglycemia. Sure, hypoglycemia can be seen and is happening with type 1 diabetes, but in that case, it's really too frequent. So for sure, there are some adjustments that can be made there and So that's one of the first thing I do look when I look at the data. So this is really an important slide that I take the time to show to patients when I see them at the first clinic. So if you see your doctor, that's good to have this in mind. So to be aware of what you can expect in terms of the impact of your pregnancy on your diabetes. So if you look at the bottom line, so this is really the weeks of pregnancy, starting from 0 until 42. For sure, you won't go up to 42, but that's just to give an idea in terms of the weeks of pregnancy and the timing. And on the other axis, this is really the insulin requirements. So as you can see, there are kind of like three stages of pregnancy in terms of your sugar. So the first part, so the week 1 to 9, you will see a slight elevation in your sugar, like between like the week 5 to 9. So that's why like that's a moment where you can see, oh, my sugar rising, and then that'll be important to make some adjustment. So basically, when the insulin requirement like go higher, that means you're being more resistant to insulin. It takes more insulin, so we need to increase the dosing in parallel. The second stage of pregnancy, usually happening between week 9 to 16, is a moment in pregnancy at higher risk for low blood sugar and hypoglycemia. That's a stage of pregnancy that women will typically have nausea, vomiting, loss of appetite. So that's a period you can have lower sugar, and that's why it's really important to be aware of that. So what you can expect and to be ready to make some adjustment if needed. The stage 3, this is really what is typically related to pregnancy. So you see this sharp rise in your insulin requirements, like starting from week like 22 up until like 34 weeks. So this is a timing of pregnancy that because of the hormones made by the placenta, there is really much more insulin needed because you develop like a resistance to insulin. So you really need to make some adjustment to increase your insulin dosing in order to keep your sugars in a target range. So at that stage of pregnancy, it can be frequent to make some changes in insulin adjustments like every 2 weeks, and sometimes even like 2-3 times per week. So, and the key to success is really to be aware of those changes that are coming up and to anticipate them and to be proactive in adjusting insulin dosing. That's why I was mentioning earlier that even if I talk to the patient and if I see the patient every 2 weeks, a lot can happen between those 2 weeks. That's why it's really important to try to make some adjustment at home. So this is something I like to share with my patient. So we saw that insulin requirements are going up during pregnancy, especially in the second half of pregnancy. But it will be especially with your bolus insulin. So the rapid insulin will increase a lot more than your basal or night insulin. So we typically say that basal insulin will go up 1.25 to 1.5 fold increase, and the bolus will increase 3-4 fold increase. Sorry about that. So this is a clinical example that can help like showing you. So let's say we have a patient in early pregnancy. She's using Tresiba, which is the long-acting insulin, 8 units at bedtime. So that means like approximately 40% of our insulin dosing by day is with basal insulin. She's using Admelog, which is a rapid insulin with meals, 4 units with meals. So this is approximately 60% of our insulin per day, which is rapid insulin. The same patient, end of pregnancy, just because of the changes in insulin requirements at the end of pregnancy, she's now using Tresiba 12 units. So this is now 20% of our total daily dose, which is really long-acting or basal insulin. So it did increase, but not that much. But if you look at the rapid, so she was using 4 units of Admelog, and now she's using 4-fold increase, so it's 16 units per meals, which is now 80% of our total daily dose, which is rapid insulin. So that can be impressive for a patient. Like you have your diabetes, you're used to give like a certain amount of insulin per meal. And now like things are changing really quickly, and patients tell me like, what's happening? Like I'm scared to give that amount of insulin because it's really a lot, but that's normal, that's expected. So to know this and to be aware of this can really help to know how to deal with that. One other big aspect of glycemic control in pregnancy is to synchronize the insulin dosing with the meals. So I'm really talking here about the rapid insulin. You need to be aware that there's a significant delayed onset of insulin action during pregnancy. So that means it takes time to insulin to make its effect. So usually even outside of pregnancy, sorry, we do recommend to give insulin before meals most of the time, but that's a really, really important concept in pregnancy. So we will really strongly recommend to give that bolus of rapid insulin before eating. In the first trimester, so that's 0 to 12 weeks, I typically recommend like a 10 to 15 minutes before the meal. In the second trimester, from 13 to 27 weeks, that can be 20, 30 minutes to give the injection or the bolus if it's an insulin pump before the meal. And in the third trimester, so the last third of pregnancy, that can be up to 45 minutes before a meal. I know it can be like a lot. It can be scary to give the insulin as much time before the meal, but it takes so much time to have its action. So it really, really helps to have a good control. And more importantly, that will be at breakfast. That's the moment of the day it takes the most for insulin to make its effect. So that's a really clinical example. So that was one of my patients. So if you see at that day, she gave insulin with breakfast. So at the same time, she gave a shot of rapid insulin and then she had her breakfast. And you can see that her sugar like went higher. She didn't give any correction. So that was only the effect of insulin, and like 3 hours after the meal, then she had a low blood sugar. So, and this is happening because this hyperglycemia is explained because she was eating and the carbs were absorbed, but the insulin wasn't having any effect at that time. And the insulin effect happened too late, and then she had her low blood sugar. And this is really a good example that at that day, she gave insulin 30 minutes before her meal because she was approximately the second trimester. And then she had breakfast 30 minutes later. And then she had kind of a flat line, which was really good with the same dosing of insulin she had at that day. So it's not that she increased her dosing. It's really the timing of the insulin with meals made a significant difference in her control. Proportion of patients with type 1 diabetes will use insulin pump. So over the last years, we now have access to automated insulin pump. Basically, it's a pump that will communicate with the sensor to make some adjustment in your basal rate, so the insulin administered by the pump to have your glucose under good control. We currently have 2 pumps available in Canada in automated mode. And basically what it's showing in pregnancy with those systems is that people will have improved blood sugar control, especially overnight, which makes sense because that's a time of the day when people are not eating. So it's easier for the pump to really achieve target glycemic control while making some adjustments in the basal rate. People will report better sleep quality. Many of my patients will tell me, you know what, like I've never sleeping so well. Like I don't have to worry about my diabetes, about waking up with hypoglycemia or higher sugar. So it's really improving the sleep quality. It improved the time spent in hypoglycemia as well. And the thing my patient will tell me it's really that it's reducing the burden associated with diabetes. So the diabetes burden will be better with those systems. I'm not telling for everybody, but in general. So that's something being more studied in pregnancy over the last years. So I think that will be something interesting for the future as well. So a word about delivery. So as an endocrinologist, and I won't be the one making the decision on when when you will deliver, and will that be induction? So this will really be discussed with your obstetrical team. But general principles that I could say is generally induction will be planned around 38 to 39 weeks if there are no complications. But for sure, many factors need to be considered for that decision. The glycemic control, the estimated birth weight based on the ultrasound, if there are some diabetes complication, is there preeclampsia? So there are many things to consider, but in general, obstetrician would discuss with you in induction around 38, 39 weeks. During delivery, you'll have maybe two options. But for patients who are using insulin pump, they can keep their pump like throughout delivery if they want to. The other option for a pump user or for people who have injection will be to have an IV insulin drip, so a perfusion of insulin while you come in at the hospital. That will be really managed by the nurse. So if the sugar is going higher, she'll give more insulin with the perfusion, and if it's going lower, she'll suspend it. So you don't need to take care of that. They'll be really been taken care of by the team at the hospital. But that's really the standard with the IV infusion. And we'll try to maintain your blood sugar between 4 to 7 during the delivery. Postpartum. So this is really important as well, because I did mention earlier that the insulin dosing will increase significantly during pregnancy, but it will decrease significantly as well after pregnancy. So in a few minutes, when you deliver the placenta, the insulin requirement will really, really go down quickly. So it's really important to plan this and to plan the insulin dosing after delivery. So personally, when the patient will be approximately like 34 weeks, 35 weeks, I will meet her to discuss the delivery, what she can expect in terms of changes in her sugars, and I will make like a really specific form to fill up the dose I will prescribe after delivery. I'll give a copy to my patient so she's aware of that. But really, we typically take the dosing of insulin my patient had at the beginning of pregnancy or before pregnancy, and we cut 30% reduction of that. So that's really impressive how quickly we need to step back on the insulin dosing. If we don't, that will result in hypoglycemia, and we don't want this to happen. I also discussed during pregnancy, we change the target range between 3.5 to 7.8. But after delivery, we'll go back to the typical target range, which is 3.9 to 10. I really prefer my patient is standing at 12 of glucose instead of 4 and being stressed out while she have the baby. She's trying to breastfeed. And so we really want to change the mindset there. Breastfeeding is encouraged. It can help reducing the risk of neonatal hypoglycemia for the baby, and it can help prevent offspring obesity and diabetes. One last slide, because that's a question often asked with the patient with type 1 diabetes is, will my child develop diabetes? So two things there. One is about the control in pregnancy. So if the diabetes is poorly controlled during pregnancy, that can increase the risk of your baby having hypoglycemia at birth for the first 24 to 48 hours. It can also increase the risk of type 2 diabetes and obesity in adulthood, but really of type 2 diabetes, and this is really related to control during pregnancy. The risk of your baby having type 1 diabetes is approximately 5% if the mother has type 1 diabetes. It can be up to 25% if both the mom and the dad have type 1 diabetes, but this is not really frequent. So usually the question will be like when the mom has type 1 diabetes, so I will discuss like the 5%. So conclusion, importance of pregnancy planning. I think it's important to discuss your plans for pregnancy with your doctor, and the glycemic control before conception is really important as well. It can really help reducing the risk of complication. More strict control is required during pregnancy to reduce the risk of complication, and we talk about the different target range there. There's a significant increase in insulin requirements in the second half of pregnancy. So it's really important to be proactive with insulin adjustment, to try to make those adjustments at home as well. And this is especially with rapid insulin more than basal insulin. It's really important to pre-meal bolus, which means we need to increase the time between the injection or the bolus and the meal. And there's a rapid reduction in insulin requirements after delivery. So it's really important to be prepared for that. And that will be done with your diabetes team during the third trimester. So thank you for your attention. We'll take some questions or comments.
Thank you, Dr. Lemieux. This was very informative. I think it gives a good overview to for women, either when preparing for pregnancy, during or after. So this was, I think, greatly appreciated. We do have one question coming from one of our audience members concerning the first trimester, when we know there's a lot of nausea and vomiting. And although she knows it's best to pre-bolus, sometimes one of the advice we give is to eat straight when we wake up to avoid the nausea. So any tips on that, how to pre-bolus?
Yeah, that's a good question. And there's two things there, because the first one, I know that eating right away before, like when you wake up, can help like prevent like morning sickness. So if you feel confident you'll be able to eat, you can just like at least 5 minutes or just a few minutes before is better than at the same time or even after. But something I didn't discuss, and I really talked with my patient, like security is still the first thing and the most important thing. So if you're having like a lot of nausea, vomiting, you're not sure you'll be able to eat, I really prefer you eat and then you bolus, even if it's not ideal. But I don't want a situation like the patient gave like insulin 15 minutes ago and then is not able to eat anything. We're stuck with that insulin. So at that special time of pregnancy, when people are really struggling with nausea, I recommend security first. I know it's not ideal, but at least we don't have like bad low sugar.
I think it makes sense, and it's a realistic recommendation, because there are guidelines and then there's real life.
The real life.
So I invite, if we do have another question that came up, if anyone else has questions, feel free to write them in the Q&A. Regarding exercise during pregnancy, what would be your recommendations? Would they be different for someone that does have diabetes or not?
That's a good question. I think exercise is really good in pregnancy. I don't think it's the time, that's a general pregnancy recommendation to start running if you never done so before, but to be active is really important. If your sport you're being used to, I think it's good to continue. I mean, depending on the sports for sure. But especially being active, and even like walking after the meals can really help get your sugars down. So it really helps. The sugar is consumed more quickly by the muscle, and this really make improvement in your sugar. So I really think physical activity is good in pregnancy for sure, unless you have like different consideration like regarding pregnancy itself from your obstetrical team. But I think it's really important to be active, and that can really help you control.
Would integrating exercise in sort of your routine help adjust the doses if it's like daily?
Yeah, that's a good, I mean, if it's more like recurrent and like more regular, that will have like a general impact on your sugars. But for sure, like if a patient I don't know, is training at the gym, and that's like 2 times a week at a really specific moment. Maybe at that time, I will recommend to adjust insulin dosing, especially with the rapid insulin, because if that's something like not regular, it for sure it can have some issues with lows. So I will discuss and make some adjustment with the rapid insulin before the training. But if that's something like more daily or a small walk, normally I won't recommend to make some adjustment, but that's for sure depending on every person.
So you did discuss about pumps and AIDs during the pregnancy. We know there are 2 commercial systems available, but some people are doing looping. So just for those who don't know, these would be DIY technology, which where you link a sensor to a pump with an algorithm. So it's not like a commercial system, but there's a very good online population and support for these DIY systems. Any recommendations or insights about those in pregnancy?
Yeah, really good question. I've been trained in Calgary, and the DIY was really more frequent. As I had more patients using DIY than in Quebec. There's many things there, but I think as an endocrinologist, my role is really to support those patients. I cannot recommend like from a medical perspective, but for sure I do really support those patients and help them make some adjustment. And we did publish something about the case series of DIY in pregnancy because we had a lot of patients. And I think like what's the really advantage of the system is that you can customize everything. So I think when the future in insulin pump in pregnancy will be to have like lower target in terms of your glucose. In those systems, I remember having some patient and we were aiming for like glucose of like 5, which we can do in commercial system. And that's something like more pregnancy specific. So I think people can really achieve good control. We need to support them and that's the same adjustment. But yeah, so it's working well. But I admit I don't have a lot of people in Quebec, but that was something really frequent in Calgary.
I guess in those cases, you really work with the patient that
exactly
knows your system very well.
Yeah, because I won't be the one like building the system with the patient. That's totally not my role. But once the patient is on the system, for sure, I can support them and make some adjustment with them.
So I think that's really interesting. Thank you. We did answer all the questions that are online, and our time is coming up. Before we close the webinar, I just want to let the audience know we do have the Type 1 support training platform, which you might be aware of, that is open to all adults with Type 1 diabetes in Canada, and it has courses and information on some of the topics we covered today, such as reading CGM reports, adjusting insulin. There's an introduction on pregnancy. So if you want to create an account and have access to that, it's type1support.ca, the website. So thank you again, Dr. Lemieux. I think this was very informative, and we will put the recording of this webinar up on our website shortly. So thank you.
Thank you so much. Have a good day, everyone.
Okay, bye-bye.